The next set of discussion is going to be on abnormalities of cardiac conduction and what are the things that are associated with cardiac dysrhythmias. And then we're going to talk a little bit more about the actual treatment modalities. So this has been discussed a little bit and we talked about cardiac pathophysiology, but we're going to go into a lot more of the details of how to treat these issues. Okay? Arterial hypoxemia should always be on the top of your list. Tissue ischemia, electrolyte disturbances, anything that causes acid-base disturbances, induction of catecholamines, and coexisting cardiac diseases such as pre-excitation or QT interval syndromes can also cause significant cardiac arrhythmias. This is a really nice picture in Adam showing you how the SA node is located in the right atrium. Anyways, it's in the right atrium, and it shows you how it actually breaks up into the different branches, going to eventually to the AV node, and then sending the His Purkinje systems down to the left ventricle. I think the battery's dead. Okay. Action potential. We talked about this before. What I want you to make sure that you understand is that the alterations taking place to increase or decrease heart rate is really in the depolarization effects in phase 4. In phase 4 of the actual pacemaker cells, it doesn't stay at baseline. Instead, it begins to increase gradually. This alteration can actually take place via changes in the actual neuroreceptors, neurotransmitters inside the heart. Specifically at the SA and the AV node. Okay? So this depolarization rate can actually be altered by things that occur inside these transmitters. Now what you see is acetylcholine binding will actually suppress it by basically activating what's called a G-activated protein. That G-activated receptor will cause potassium channels to open, and it will cause a decrease in the slope, which will actually begin to decrease heart rate. As for norepinephrine acts also on a G-coupled protein, which in this case does not open up potassium channels and actually inhibits it, and as a consequence causes a more rapid upstroke, increasing heart rate. So norepinephrine is on the, of course, the beta-1 receptors versus the acetylcholine receptors or the muscarinic receptors in the heart. The action potential as a consequence will be can be changed simply by the degree of slope change in the phase 4. Now, increases in the phase 4 slope will actually cause the heart rate to increase. Things that will cause stress, such as arterial hypoxemia, hypercarbia, catecholamines, sympathomimetic drugs, hyperthermia, and hypertension will induce this problem. Decreasing the slope will, of course, be the vagal stimulation, which causes the receptor that I just talked about, the muscarinic receptor, to be activated, leading to more potassium coming out of the cell, which decreases the slope, and as a consequence causes a delayed in heart rate. The other things that can actually make the decrease in slope is positive airway pressure and acute hyperkalemia. Now, the diagnosis for arrhythmias, we sort of talked about this last semester, but I'm going to go over it very briefly. As you work through the arrhythmias, is to look for abnormal conduction. Where do you think it's originating, and why? What kind of rhythm is it? Fast, slow, or is it absent? Mechanisms of arrhythmias are increased automaticity in normal conduction tissue or an ectopic focus. You can have re-entry of electrical potentials, or you can have triggering of abnormal cardiac potentials due to depolarization. Cardiac conduction normally will occur in the SA node going to the AV node, which then causes your P wave. The PR interval, which is the isoelectric, is due to the AV node holding electrical signal for a short period of time, so the atrial contraction can take place. This is followed by the activation of the signal, sending it down the bundle of His, doing the His Purkinje fiber system, causing your QRS to be initiated. Reentrant arrhythmias can be described as either being intrinsically inside the actual conduction fibers or exterior to them. If they're outside of the normal AV valve, sorry, the normal aortic, sorry, the AV node, things like WPW, they're at much more risk for rapid reentrant arrhythmias. The other one that's found as part of it is, what's the name? Longanong syndrome is the one that's inside the AV node and tends not to go as fast when you give verapamil in that situation if you make that mistake. Arrhythmias is to correct the source. The antidysrhythmic drugs, which I'm going to talk in a lot more detail, cardioversion, artificial pacemaker may also be considered, including non-invasive transcutaneous cardiac pacing to invasive cardiac pacing. Now, the things that you're going to see is you're going to see things like first degree, second degree, or unifascicular blocks, or bifascicular complete heart blocks, such as third degree AV block. You have to be able to diagnose these for the test, which is still, I'm holding you to that. It's not going to change when you get to clinical. Okay, know the difference between Wenke-Bach, Mobitz 1, and Mobitz 2. You can keep going. Right bundle branch block, you're expecting to diagnose, okay, versus left. And the importance of this is still continuous. So this is it's a reiteration of this. Left bundle branch block is important because it recognizes in placing the PA catheter. If you have already a left bundle branch block, when the PA catheter is inserted, you can actually completely hit out the the right bundle and cause a complete heart block. Third degree heart block, look for your the PR. The P wave's not connected at all to the QRS. Okay. Causes of that are primary fibrous degeneration, so just simply aging, inadequate oxygen, inflammatory reactions, sometimes due to iatrogenic cardiac surgery. Sometimes you see it in congenital heart disease as well. Disturbances that you expect are all the following, which I already, we've reviewed this before. I'm just going to go over it quickly. Sinus tach, I expect you to know. What are the causes of sinus tach? Things like anything that decreases oxygenation, so arterial hypoxemia, breathing or ventilating hypercarbia will cause this as well. Circulation-wise, hypovolemia, hypotension will also induce this. Anything that induces pain, fear, or anxiety will cause this. Light anesthesia will also cause sinus tachycardia. The other thing you'll see is an increase in sympathetic tone with sinus tachycardia. So myocardial ischemia and infarction, congestive heart failure, PE, all these things can cause sinus tach. Drug-induced increases in heart rate include atropine, sympathomimetic drugs, caffeine, cocaine, amphetamines, and nicotine. Treatment is basically correct the underlying cause. It's actually a very common problem. It's usually volume, and very last you should consider beta blocker. This should be pretty last on your list. You treat the underlying problem first. Sinus bradycardia, slow heart rate less than 60. Altered mental status may be symptoms of it, as you're not getting enough perfusion to the brain. Causes dizziness, seizures. Some people actually will develop angina and develop as well congestive heart failure. If it's severe, and the degree of contractility issues as well as being low. You tend to get also other end organ failures and maybe manifestations of cardiogenic shock. What you see is what are the causes of sinus bradycardia is overvagal stimulation. So if you see this in the operating room, it could be that there's too much traction being placed during abdominal insufflation, or the surgeon's actually grabbing the peritoneum, or the patient, the surgeon's working on the eye, and he gets what's called oculocardiac reflex. You can also have celiac plexus stimulation due to the traction of the mesentery. Drugs such as beta agonists and calcium channel blockers and opiates can actually act as cause severe bradycardia. Succinylcholine is usually not causing sinus bradycardia unless you do a secondary dose. Okay, not the primary dose, but the secondary dose. The primary dose of succinylcholine will usually only bind to the nicotinic acetylcholine receptors, which are ion channel receptors at the muscle level. Okay, if you give a secondary dose, all the sites were pretty much all blocked. So what's going to happen now is the succinylcholine, which is basically looks like acetylcholine, will then bind to the muscarinic sites, and as a consequence cause a bradyarrhythmia, just like acetylcholine would be bound. Okay. Sinus bradycardia is also seen in hypothermia, hypothyroidism. Sometimes it can be seen in normal hearts, such as athletic hearts, and patients with sinoatrial node disease. Treatment is no symptoms, just watch. Okay. If it's severe, then you want immediate treatment of atropine. Please give at least 0.5 milligrams of atropine or 0.4. The same thing with glycopyrrolate. Give at least 0.4. Don't give 0.2 milligrams. You can get just a partial blockade of the receptor, and as a consequence get a severe drop in heart rate that worsens. Okay? Epinephrine or dopamine infusions may be titrated to response while waiting cardiac pacing. Do not be very, very careful about using isoproterenol if you have a low blood pressure, because that actually, if you have a cardiac arrest with isoproterenol, you may actually cause a 100% mortality rate because it's such a venodilator. Okay? Glucagon may also be helpful in some patients due to beta blocker or calcium channel blocker overdose that's unresponsive to atropine, because what glucagon does is it bypasses a normal receptor. It goes through another non-mediated beta-1 receptor and acts the same thing as a beta-1 action drug, which is increases cyclic AMP. So glucagon can also be useful when your beta receptor is completely wiped. Okay. 6, sinus syndrome is the most common reason for pacemaker placement. You can see this nice big pausing areas. These people will become syncopal, and usually these are guys that run into the 7-Eleven with their car. This is what they're doing. Okay. Atrial premature and junctional premature beats. This is a high junctional, showing junctional tachycardia. When you get lower, you'll see that the QRS will get wider. This is supraventricular tachycardia. Supraventricular tachycardia can be from multiple sources, including atrial fib, atrial flutter, so there could be other reasons for supraventricular tachycardia. Usually you see 160, 180 heart rate. It could be also WPW, so you got to be careful not to begin to treat this as just a regular SVT and try to treat it with verapamil. You may actually get in really severe trouble. You can sometimes consider doing a vagal maneuver, but now with the new drugs that we have, the primary drug of choice is adenosine. Okay, so we tend to give adenosine, followed by calcium channel blockers is another consideration, but I'd avoid verapamil. Beta blockers, I tend to use beta blockers before I would go to calcium channel blockers, and then digoxin. Atrial flutter, simple. They need to do diagnosis and then give me the reasons. Most of the time, the reasons are due to dilation of the right or left atrium or hypokalemia. These people are very, if they're symptomatic, you need to do electrical cardioversion. It does not take a lot of joules, only like 50 joules to do it. If they're asymptomatic, you can consider doing overdrive pacing, or you can actually control the AV conduction using drugs like amiodarone, calcium channel blockers like diltiazem, and procainamide. Atrial fibrillation basically loses all kick. As a consequence, it can become very severe problem in some patients. Causes of it are rheumatic heart disease, hypertension, thyrotoxicosis, patients with bad COPD, patients with alcohol intoxication that is acute, and patients with acute pulmonary embolus. Treatment includes cardioversion, but atrial fibrillation is a little bit more difficult to shock out of, so it requires defibrillation. Cardioversion at 100 to 200 joules. The difference between cardioversion is you're firing on the cue, so you want to make sure that the machine is actually picking up the QRS. The other thing that you consider doing is switching over to drugs. Okay, some people use amiodarone. Okay, sotalol, which is a beta blocker, and calcium channel blockers. Multifocal atrial tachycardia. Okay, it shows you that it's causing from multiple sites of the atrium is causing the SA node firing. These can be seen in patients with COPD, and it could be from theophylline toxicity. So you have to be very careful when you start seeing multifocal atrial tachycardias. Usually it converts into a more malignant arrhythmia with theophylline. Theophylline is almost never used in the operating room because when you combine it with the volatile anesthetics, you can get some really nasty arrhythmias, including VTAC, especially when you use Halothane in the old days. Sepsis may also be a reason for why you're seeing this in metabolic and electrolyte abnormalities as well. Multifocal atrial tachycardia, and the way you treat it is reverse the pulmonary problems. A lot of times you're having oxygenation issues or you need to bronchodilate. Pharmacologically, it's limited. Magnesium may be a drug of choice Verapamil is one of those few times where you should consider using it. And beta blockers, as long as you don't have having bronchospasm. Cardioversion has really no effect and doesn't really improve the situation. Junctional rhythm depends on which portion and how fast it is, or the actual height of the how wide the junctional rhythm. The wider the junctional rhythm, the lower it is. In other words, it's right below the AV node. The higher the junctional rhythm, the more encompassing the AV node it is. Wandering atrial pacemaker, we just showed you again. So keep going. Ventricular premature beats are absence of P wave preceding the QRS. So you can see here. That's a ventricular premature beat, or PVC. It has an inverted T wave associated with it, so it's going in the opposite direction. And it has a compensatory pause. Many times, PVCs do not have associated contraction associated with it, so you want to make sure that look at your pulse oximeter number, which tells you how many beats it's actually sensing versus the EKG. The EKG will still read this as a beat, but the actual pulse oximeter will not read it if it's not pulsatile. Okay. Great. Okay, so what are these things associated with PVCs? You got normal ischemia, normal heart. You can have ischemia. You can have inflammatory processes. Okay, there's a lot of things that will cause issues with this. Hold on. Sorry. VTAC, okay, is something that, of course, you don't want to see. There's two forms of VTAC, unstable and stable. Ventricular fibrillation is incompatible with life, so if you ever see this, immediately you need to defibrillate these people. Epinephrine and vasopressin are your high-end choices. And then you have pulseless arrest, which, of course, is going to cause no pulse. Means that you need to start doing CPR, okay? Things that will cause this will be hypoxemia, hypovolemia, hemorrhagic shock sometimes will cause this. Electrolyte problems, hypoglycemia will also induce this, although rarely. Hypothermia, drug or environmental toxins, mechanical obstructions such as cardiac tamponade, tension pneumothorax, coronary ischemia, or pulmonary embolus. All these should be very high thought of as for causes of PEA. Okay, make sure you know that for the test. Pre-excitation syndromes are broken down in WPW, Longanong, Mahim, and prolonged QT interval. The only thing I'm going to talk about is WPW briefly. And WPW is the delta waves that are evident right after the P wave, which indicates that you have an accessory pathway. That accessory pathway is actually outside of the AV node area. As a consequence, if you block this down, it causes rapid reentrant rearrhythmias to take place. And it's not something you want to have, and giving verapamil can be very deleterious in this situation. WPW treatment can be by giving adenosine. Okay, verapamil should not be anytime consideration in treatment. Beta blockers may also be considered. Antidromic or wide complex AV node reentrant tachycardia. The above treatment is not effective. Verapamil may actually cause VFib, and procainamide and cardioversion are the only choices that you have with this kind of situation. Catheter ablation is usually a treatment of choice over time. Never treat with verapamil. Anesthesia concerns that you have is induction of pentothal with history has been effective. You want to avoid ketamine. Maintenance is nitrous and volatile anesthetics have been found to be safe, but the Pavilon will actually will induce the WPW to emerge sometimes. And as for emergence, should you reverse somebody, I still reverse people with this problem. Just go, you can't go easy, you got to just go and give it. But it's really unknown if it's completely safe. I've done it on 2 people that had WPW, and they both reversed adequately and didn't have any problems. The Longanong-Levine syndrome also is a delta wave, but it's not. It's part of the AV node accessory pathway, so they tend not to have as much problems with rapid SVT as WPW does. Okay, volatile anesthetics will actually prolong QT intervals. Okay, and beta blockers and other drugs that are antiemetics will also cause this problem. they were trying to get us to not to use Zofran because they're saying that it would prolong the QT interval. It does do it, but only the high doses like they use for the chemotherapy.